Hey guys, and welcome to our micro exam 4 review for lecture. So in this lecture, I'm going to be using the study guide that's posted as like a rough backbone. But just to let you know, majority of this exam as well as the next exam, you're most likely just going to need to know the characteristics of the diseases, and then also like how to differentiate them. So if you know the characteristics of the disease, then you know how to differentiate them. And then also maybe like a handful of application questions, but that's about it, such as like um I can't even think of one off the top of my head. But like if I were to give you like a case study or something, then I would want you to know, based off of the information that I gave you, what can you like diagnose the patient with, or like what's the causing organism essentially. So stuff like that. But I'm gonna go ahead and walk through all the diseases and everything, and highlight the big like hallmarks um, for each disease or each infection. So with that, let's go ahead and just go in order. So we're going to start with chapter 19. So chapter 19, I will ask you how to tell the difference between these rashes. Definitely know this figure. So with this figure, I'm just going to go ahead and tell you the four so you can study them properly. So A, ooh, excuse me. So A is the macular rash, B is the vesicular, and C is the papular, and then D is the pustular. So the difference between the vesicular and the pustular is the color, as you see. So um, the the pustular does have that whiteness to it, so kind of like a really juicy pimple, whereas B does not have that white off yellow color to it. And then also know the difference between exanthemus and anthymatous rashes, which can be found in chapter 19. So the differences between them, let me click through. So here's the differences. So exanthemus, this is normally associated with systemic infections such as like headache, fever, malaise, fever, and so on, whereas the other one is just associated with rash on the mucous membrane, such as the oral cavity or the vaginal cavity. Okay, so with that, I believe it just takes us directly into diseases. Yes, it does. Oh, and also, guys, with all these diseases, some good case study questions and everything to get your practice down are in those supplemental PowerPoints. So definitely take a look at those. Those are extremely helpful when studying, because I may even use a very similar case study on the test or even some questions. But definitely take a look at that. Okay, so let's go ahead and just jump in. Measles, chickenpox, herpes. Okay, so let me click through. There we go. Measles, are also known as rubella. So definitely know the presentation of it. So the presentation with measles or rubella, it's generally a very, very contagious infection. It does produce a full body rash. Excuse me, guys, sorry. So like I said, it does produce a full body rash, as you can see, but then also it can produce a rash on the mucous membranes, and it's known as Koplik spots. So that are like those white little dots that you can find in the back of your throat. So just know the general presentation of rubella, which is as follows. And then also another little fun fact about rubella: it can actually cross the placental barrier. So just another little fun fact. Whereas like other, I'm sorry, not rubella. I'm sorry, I'm thinking of something else. I'm thinking of German measles. Just kidding. So discard that terrible fun fact. Um, so yeah, that's pretty much it. So let's go ahead and do herpes, like chickenpox and everything. So chickenpox is caused by the varicella zoster um, viruses. So with a chickenpox exposure or even a herpes shingle outbreak, what will happen is that you'll get that macular rash and then sometimes even pustular. It kind of just depends on how severe it is. And then also with the shingles, you can get the vascular rash. And then what will happen is that after the initial exposure, then the virus, what it will do, um, it will retreat and remain dormant inside your ganglion, and then if it happens, it can reemerge as shingles. So, but in order to get shingles, you have to have chickenpox first. Some people will never get shingles after they get chickenpox. It just depends. And then also how it's transmitted is through the inhalation of particles from skin lesions. So what will happen is that like if a child gets it, children are playing, and then the rashes can rupture essentially, and then the little viral particles that are inside of those ruptured skin particles, um, it will be transmitted through inhalation and then as well as through adults. So like if an adult has never had chickenpox before, but then like their child has it, they're at risk of getting it, and it's actually a good idea for the parent who has had chickenpox to take care of the baby rather than the adult taking care of the baby, just so another parent doesn't get sick, just to prevent spreading. Okie dokie. Um, believe what was the next one? Oh, so actual herpes and smallpox. Okay. So actual herpes. So there's two different types whenever it comes to cold sore and genitalial herpes. There's HSV1 and HSV2. So this is a different quote unquote species of virus. It's not really a species, but it's a different type. But they're herpes simplex also belongs to the varicella zoster family, but they cause different types of infections. So with HSV type 1 and 2, it affects the mucous membranes, the central nervous system, and then sometimes organ systems, but not so much. But normally it's the mucous membranes and the central nervous system. So this one is spread a little bit differently. Oh, excuse me. So it's spread through direct contact, um, generally through like sexual contact, but it doesn't have to be. What can happen is a simple kiss. So, like if a person has a cold sore on their lip, and then you kiss somebody who doesn't know that they have a cold sore or something, then that person can transmit it to the other person. Then they can have an outbreak, and it spreads that way, or it can spread through direct sexual contact. So, if somebody is just about to start an outbreak, or somebody who just ended outbreak, a lot of times people during an outbreak, it's hopefully common sense not to have sex because it can be very very painful, because these blisters are extremely painful. But generally before and after a an outbreak, you generally are, it's called asymptomatic shedding. So you don't have any physical presentation of it, but you still have viral particles on your skin that you are shedding at the time until you get essentially new skin. So that is a lot of times where it will happen. Also, HSV1 is is associated with oral and genitalia herpes, whereas HSV2 is solely genitalia as of right now. Normally, people who get HSV1 genitalia in the genitalia, it's because of oral sex that occurred from a person had a cold sore on their mouth and then oral sex was performed. That's generally the route of transmission, is through direct contact, through sexual acts. Okie dokie. So that is herpes and herpes, and then let's go to warts and smallpox. So, warts. So HPV is cause genital warts. Specifically, certain subtypes of HPV will cause genital warts, but there are other HPV viruses that don't cause genital warts. Um, they'll cause warts on all warts on the body is caused by an HPV virus. Now it'll determine which virus based on sometimes based on region of the body, but other times not so much. But we're going to be talking about genital warts for the most part, and that is generally caused by HPV 6, 11, 16, and 18. Those are the main ones. So this is also transmitted through direct contact, either through like person to person or person to contaminated surface. So with warts, there are some subtypes that are more associated with cervical cancer. That is why we actually have a vaccine that is available specifically against that HPV virus, or viruses actually. There's multiple types, and that's Gardasil. So with having the vaccine, it can definitely lower the risk of having cervical cancer caused by HPV. So I will be asking questions about the HPV virus, and more specifically, I'll be actually asking you to read a study, a very short study. It's like a paragraph, guys. And then also to answer a question in regards to a graph that I give you about the HPV prevalence of cervical cancer. So definitely know that. What else? So then we have smallpox and skin infections. Okay, with smallpox, the big thing that I just want you to know is that how it's transmitted. So it can be transmitted directly or indirectly. So if it's transmitted directly, it's through aerosol droplets. If it's indirectly, it's through fomites, which are inanimate objects. And then also the location of where the virus can replicate, which is in the cytoplasm of the cell, and then general hallmarks of it, which are the two different types of rashes that will occur. You'll get some small rashes on the mucosa membranes, and then the true presentation, in my opinion, is the mox pustules on the skin, which will look like this rather than on the mucosa membrane. So that's pretty much it about smallpox. Smallpox is, in my opinion, kind of boring, but it is very much prevalent in our society. Okie dokie. Yeah, I believe that's it I wanted to say about smallpox. Like I said, it's not one of the big ones that you'll be seeing a lot of. So I care more about like the chicken pox, the herpes, the HPV, stuff like that. Okay, so let's go ahead and go into skin infections. So we have staph and we have some strep. Oh, no, so sorry guys. I don't know why I'm yawning so much. Okay, so for some staph infections, so it's generally caused by Staph aureus. I'm going to mainly focus on that species because of the fact of how it presents. Sometimes staph epidermis can also cause infections, but generally Staph aureus is the big one because of all of the presentations that he can do. So like I said, there are multiple clinical presentations of him. So there's two main types, it being superficial and deep. So if it's superficial, and then it causes like folliculitis or a boil, or also known as a, what's it called, a furuncle. So that's like a deep boil. Or there's carbuncles, which is where they're like joined together, as well as a sometimes it does produce a toxin, and that toxin will produce this kind of like white layer on the patient. So these pictures, so like the first one is like the furlicatitis, and then the second one is the not the carbuncle, the furuncle, so the boil, because it's only one, whereas a carbuncle, that is two, so you see two white heads. And then this one is the presentation of the exfoliative toxin, which is where the top layer is essentially being shed. There are other staph diseases that are caused by toxin producing strands, but just for this one, just know in terms of Staph aureus. Okie dokie. Then now we have strep. So strep is a pretty nasty one. He's the one that actually causes necrosis as compared to staph. So that's one big difference between them, is that strep causes necrosis. Also, with strep, he can do different presentations. So he can do two different types of necrosis. So he can do type 1, where he's associated with other microbes, and then there's another one where it's only caused by one microorganism, whether it be S. pyogenes, which is normally the species caused by strep, or there's Staph aureus. But normally it is Strep pyogenes if it's only going to be him. But there's other species as well, such as Clostridium or Vibrio. But for this, in this term, we're just going to focus on strep in terms of clinical presentation. So the reason why strep is so difficult to treat is because he has a multitude of virulence factors. So since he has so many virulence factors, that also aids in causing disease, and it makes him very, very difficult to treat. Okie dokie. I think that's the big picture of strep, at least at this point. Let me just make sure, guys. Yeah, I believe that's the big picture with strep. Yeah. But then also don't forget there are strep infections associated with respiratory infections, but we'll do that when we get to that chapter. Okie dokie. So let's also look at other ones. So we have burn, gas gangrene, and eye infections. Okay. Oops. Okay. So we also have oh, here we go. Here's some burn infections. So burn wound infections, I definitely want you to know this, guys. Some of you might end up working in a burn unit or in ICU, so definitely know this. So I do want you to know the different presentations between burn wounds in terms of having a P. aeruginosa infection. So the hallmark, if you have a burn patient and they have an infection with P. aeruginosa, you will get that green-blue pus in the wound. And it can also be foul smelling depending on what species you have inside the burn wound. And then also MRSA is probably the most common cause of burn wound infections, followed by P. aeruginosa. And then also with burn wounds, essentially everything is decreased in terms of immune response. The only one in terms of immune cells being upregulated are Tregs. So just know that. Just know the big picture. Like I said, definitely know P. aeruginosa. So he has the hallmark of the green-blue pus. I think that's the big picture for wounds. Yeah, let's go with that. Okay. And then we have gas gangrene. Okay, so gangrene. So I do want you to know the difference between the two different gangrenes. We have wet and dry, be able to tell the difference. So dry gangrene is normally associated with like frostbite or people with ill-controlled diabetes, whereas wet gangrene that's normally necrosis because of an infection, because of like a microorganism rather than environmental. That's the big picture. Um, and then we have eye infections. So with eye infections, I really just want you to know the difference between conjunctivitis and keratinitis. So conjunctivitis is the inflammation of the conjunctiva. So that is this area. So you can see all that white area of the eye, and then also the yeah, pretty much just the white area of the eye, followed with the you can see the infection because of the red, like your veins in your eye. So you can see that. So a conjunctivitis can be caused either because of infection or trauma to the eye or even allergies. So it's not always associated with a microorganism. And then keratinitis, that's the inflammation of your cornea, which can be found right here in your eyes. So actually, I believe it's 2 layers back, if I remember correctly, of your cornea. This is considered sight threatening, so meaning that if you fear that your patient has an infection of the cornea, you definitely want to get them seen as soon as possible so you can preserve sight. That's really it. I'm not too big on eye infections, to be honest. But the most common one that you've probably heard of is like pink eye. Also, know the difference between a bacterial and a viral eye infection. So this is a picture of a bacterial because of that pus that is being made. Whereas with the viral, there is no pus being made in the eye. So that's the big difference between viral and bacterial eye infections. Okie dokie. So I believe that will wrap up chapter 19. Okay, let's go to chapter 20. So chapter 20 is pretty much gonna kind of be like the same thing. So just know the presentations and then also the differences between each disease or each infection. Okay. So chapter 20. Okay. So we have the upper and the lower respiratory tract. So the upper respiratory tract is your airways, so including your nose, your oral cavity, your pharynx and your larynx, and then some of your trachea, not all of it. But for the most part, your head region is your upper respiratory tract, and then everything below that is going to be considered part of your lower. So your bronchi and your lungs is going to be considered your upper and lower respiratory tract. So with that, let me actually just look at it. Okay, so I'm just going to go in order. We're going to go to the odious media, which is the ear. So that's actually a little bit further down. So with the odious media infections, so those are the middle ear infections. They're very, very common. Most people have experienced them. Primarily in childhood, you normally had one by the time you were 2 or 3, and then it's highly associated with with daycare workers, but generally the inner ear infection, it can be caused by 3 bacterial species, so Strep pneumoniae, H. influenzae, and then M. catharhalis. So I do want you to know as to why children are more prevalent to having inner ear infections, and the reason is because of their anatomy. So children, they don't have their tube that drains, their E-tube that helps drain the canal. So what it is that in children, it's shorter and it's definitely more horizontal than in adults. So with that, they are definitely a lot more prone to developing inner ear infections because of the fact that it is shorter and it's more horizontal. So if you think about it, like if you're going to roll like a marble down a slope, so the marble would go slower in terms of being only 10 degrees on of a ramp rather than 45 degrees on a ramp. So the draining isn't as good in children as compared to adults. And then also, depending on the severity and the frequency of which a child has ear infections, the doctor may ask if you want to put tubes in there, which essentially is kind of like a catheter for your ear. Not a catheter, a stent for your ear. And it just opens it up and then aids in drainage. But sometimes they're temporary, sometimes they're permanent, kind of just depends. But the big thing, children get more inner ear infections because of their anatomy, because their E-tubes are shorter and more horizontal, which makes draining less optimal as compared to adulthood. Okie dokie. So let's talk about strep, scarlet fever. Okay. So with strep, oh, that's further down. Sorry, guys, wrong way. Okay, so with strep infections, so don't get this confused with strep infections of like the skin. We're talking about in terms of respiratory tract now. So some hallmarks of strep is definitely the pharyngitis. So I'm actually just going to go to the next one. So pharyngitis, strep pharyngitis is also known as strep throat. So some of us may even experienced it. I personally have not, so woohoo! I really don't want to. I hear it's extremely painful. But it is very, very contagious. So if you do ever get strep, definitely stay at home. But the hallmarks of it is that you have like a quick onset of fever, you have the sore throat, you have the tenderness, and then sometimes you even have some swelling of your lymph nodes in your cervical area. And then also your tonsils are very inflamed, but you don't have a cough. So with strep throat, you'll get this this redness on the back of your throat with the tonsils, and I call it your disco ball. So your I believe it's called uvula, but your disco ball, you'll also have some redness there. But some additional presentations of strep pharyngitis, if a toxin is produced, primarily S. pyogenes strands, they produce this exotoxin. With that exotoxin, it will cause a high fever along with red rash known as scarlet fever. So that is this guy, so the rash on the trunk of the body, and then sometimes even spreading down the arms. But then also patients can get a presentation of something called the strawberry tongue. Not all patients will get this, as you can see in this photo. This patient does not have strawberry tongue, but they will have this red bumpy tongue that is that literally looks like a strawberry butt. So that's an additional presentation of strep. But then also strep can cause something called soliloquies. So soliloquies are conditions that result after you've already had a strep infection. And the general presentation is rheumatic fever or kidney disease. So rheumatic fever is essentially it feels very much so like you're arthritic, and you have high fever, and you have severe soreness in your joints. Your skin is affected, your heart, and then sometimes even nervous system damage can occur. And then also kidney disease, where your kidneys begin to not function properly. So that's the big picture. Definitely we'll be asking at least one question about strep soliloquy. Okay, so let's go to diphtheria, whooping cough, tuberculosis. Okay, so diphtheria. So diphtheria is caused by a vaccine, but immunizations have definitely helped with the increased prevalence of diphtheria in the developed world. But in underdeveloped countries that do lack immunizations, there are higher occurrences of diphtheria. But then also we're starting to see a little bit more cases in the US because of that anti-vax movement. But C. diphtheria, it is a gram-positive rod, And the hallmarks of diphtheria is a gray-white membrane on the back of your throat, followed by a low-grade fever and sore throat. Also, skin lesions on the skin, they can occur and then they won't heal as long as you have this infection. But after you have the infection, they will heal. Also, sometimes if diphtheria does produce a DTX toxin, what it does is that it will cause shortness of breath, irregular heartbeat, and then also it can even cause cardiac dilation, so your heart can enlarge. But in order to treat diphtheria, you do antibiotics to actually treat for the bacteria, and then if you have a toxin being produced, a toxin producing strand, then you need to give them antitoxin. So here's the membrane that I was talking about, that white gray membrane that forms on the back of your throat. And then there's a skin lesion that won't heal, but it will heal after the infection is controlled. Okay, so whooping cough. So whooping cough, are also known as pertussis. It is caused by Bordetella pertussis. It is a gram-negative bacilli. It is super contagious. But it does have a long incubation period, and it has 3 phases of which the disease will, excuse me guys, will travel through. So we have the first phase. So this is where a lot of times it gets misdiagnosed, and the reason why it's misdiagnosed is because it looks like a viral upper respiratory tract infection, and with that, a lot of people were just like, oh, I'll get through it, because for the most part they are self-resolving. So at that point, since it gets misdiagnosed, it can go into the next phase, which is where you will actually have that violent cough. And sometimes, since it's so violent, some people have vomited because it's so harsh on their body, and that's actually how the disease gets its name, because of the whooping sound that it makes whenever you're trying to make a deep breath. And then followed by that, you will have a convalescence phase, which is where the disease will disappear over the next few weeks and patient recovers. There are vaccines against pertussis. So whenever pertussis is given in the normal vaccination schedule, children are generally protected and they're fine, but there are some times where children are too young to get the vaccine. And that's also why they tell people who work with small children who are at the age of being too young to get the vaccine to have the vaccine, so pertussis is not on them and then they don't pass it to child, because pertussis can be deadly to children. Okie dokie. So that's the big picture of whooping cough. Now we have pneumonia. So pneumonia, I will definitely be asking some questions on pneumonia. So I do want you to know the difference on how to classify them. So there's typical and atypical. So atypical, oh my goodness guys, I don't know why I keep yawning. So atypical, this is where multiple organ systems are affected, and then with atypical pneumonia, it will mimic a upper respiratory tract infection whenever it first is presented, meaning you're first infected. And it's generally caused by M. pneumoniae or Legionella species. That's pretty much the big picture of atypical. But then typical, these ones are caused by strep pneumoniae. And then also, oops, wrong way. With strep pneumonia causing typical pneumonia, sorry guys, it definitely accounts for a good portion of community acquired pneumonia. So community acquired pneumonia is whenever you just get it out and about, so meaning that you are outside of a health facility, as compared to healthcare or health acquired, hospital acquired pneumonia. So strep pneumonia, he's probably the most common among the elderly, the smokers, as well as immunocompromised patients such as diabetics, alcoholics, also with HIV patients, which will fall under immunocompromised. Um, I believe that's pretty much it for strep pneumoniae. I believe that's it for strep pneumoniae, guys. Yeah, that's pretty much the big picture for him. So, like I said, streptococcal species, in terms of respiratory tract infection, he can cause various respiratory infections as well as pneumonia, and then also he does have soliloquies, so don't forget about that. Okay, so that's all I'm going to say about pneumonia. So now we're going to go to tuberculosis. So tuberculosis, so this will also be a bonus question on your test, but it will be a question additionally on your test as well. But your bonus question will be over that movie that I mentioned in class that starred Nicole Kidman, and her character had tuberculosis. So I want you to know what's the movie title. So I'm not going to say it in the video because hopefully you were listening in class. But it does, I'll give you a hint, it does star Nicole Kidman and the guy that plays Obi-Wan Kenobi. Ewan McGregor, something like that. I don't know. He plays Obi-Wan Kenobi in Star Wars. But anyway, so tuberculosis is caused by M. tuberculosis. He's a bacteria that can definitely spread from person to person, and he spreads from person to person because he does not have a reservoir, and then it's spread through aerosol droplets. And then if you have tuberculosis, a lot of times you will have something that is called these Gonum complexes. So this is essentially it's like a bunker. It's like a walled off site of the infection. So you will produce these granulomes or these complexes, and in the effort to wall off the infection. And you can actually see that on a tuberculosis patient if you do a chest x-ray. So I definitely want you to know what those are because that is a hallmark presentation of TB. And I believe that's all I'm going to say about tuberculosis other than clinical presentation. So generally at first, whenever you get exposed to TB, you'll have a severe cough that has sputum production, and then you'll have fever, night sweats, and a lot of weight loss. So this is where TB is considered highly contagious. Then you have the secondary presentation of it, which is where tuberculosis gets reactivated. I don't know the mechanism as to why tuberculosis will go latent and then it will reactivate. I don't know the mechanism, guys. But if it does get reactivated, and the likelihood it will eventually, if you don't get it taken care of, you'll have the same presentation as primary, but the main difference is that you may have bloody sputum at this point, and then also the likelihood is that TB has disseminated into other tissues and is causing damage. So I believe that will almost wrap up this lecture. We're going to talk about angenic shift and drift real quick. So I believe that's actually this video. Oh. And if it is, guys, I highly recommend you watching. Yep, it is this video. It's on Khan Academy. So I definitely want you to watch this video on angenic shift and drift. But essentially what it is that you need to know the difference between it. So the difference between angenic shift and drift is where drift are random mutations whenever influenza will replicate, whereas shifting is this huge mutation because of two viral strands coming together and making a new one. So that's the big difference between them. So whenever we have the shifting occurring, then that's whenever we have endemic and pandemic risk occurring. Whereas endemic drift, not so much because it's only slightly changing and our body can, for the most part, adjust to slight changes. Whereas the shift, if it's completely new, our body has never seen it, and it's extremely contagious, then that is where it can go to endemic and pandemic proportions. Okay, so like I said, go ahead and watch that video on your own time. I did show it in class, so hopefully y'all remember it, but it is a very good, short, quick, like 4-minute video. Okay, so with that, we're going to go ahead and go into chapter 21. So chapter 21 covers systemic infections. So with systemic infections, I do want you to know definitely the slide, so I want you to know how to categorize different inflammation types based on region, and then also the terminology that goes with it. Okay, I believe I do ask a question about that. Let me double check so y'all can be prepared. Yes, I do ask about that. So, like I said, the likelihood is I'm going to ask you about clinical presentations in terms of the lymph nodes being infected, because it's a little bit easier to show images and describe that as compared to inflammation of heart muscles. But with with the second one, the inflammation of the lymph nodes, that has to do with this one, and the reason why it has to do with this panel is because you can see that redness along the lymph nodes. Whereas the third one, the inflammation of the lymph node vessel, that has to do with this red streak along I believe this is her arm, if I remember correctly, along the arm. So that's inflammation of the lymphatic vessel. And the reason why it's a lymphatic vessel is because you can see that it's traveling from like point A to point B. Whereas lymph nodes, that is solely in the neck region, cervical region, armpit, and genitalia region. Okay, so that's pretty much all I'm going to say about that. What's next? So the difference between septemia, sepsis, and septic shock. Which is this slide, guys. So definitely know the difference between these. So just know the presentation. This is a very much know it or you don't kind of test. So I just want you to know in terms of septemia, what is it? So this is where a pathogen has actually entered the bloodstream and is replicating. Whereas sepsis, this is where a chemical is being released into the bloodstream to fight the infection triggered inflammatory responses throughout the body. So this is where you'll get the fever, the chills. Sometimes you may even have the opposite effect. You'll have low body temperature. You may have decreased urination. You'll have rapid pulse, rapid breathing. And then if sepsis does continue to progress, you can go into something called severe sepsis, and this is where you'll actually have kidney failure and heart failure. So we don't want that. And then septic shock, this is where blood pressure of your patient will drop because they are entering severe sepsis. So this is where you'll have low platelet counts because blood is leaking and these rashes are being formed. So definitely just, like I said, just know how to differentiate between those three terms. And that should be good for y'all. So with that, I think we're going to go ahead and go into the diseases of... Yep, we're going to go ahead and go into the diseases. So, yeah, we're going to go into the diseases. So, let's talk about the plague. So the plague, I do want you, with all these diseases, infections, I want you to know the causative agent, reservoir vector, if there is one, as well as clinical presentation, and then treatment if mentioned. Not all of these, I'll mention treatment plans. But with the plague, it is caused by Y. pestis, It does have reservoir of like squirrels, prairie dogs, so pretty much like the rodent population. The vector is a flea. So what will happen is that a a human or a patient will come in contact with like a squirrel or a prairie dog while like let's say camping or hiking or something. A flea will jump onto the patient and then the flea will bite. And then at that point, the flea will cause the infection because it injected, not injected, but it the bacteria from the flea got onto the person. And then depending on that, you might get two presentations, either bubonic or pneumonic plague. So bubonic plague is where the bacteria actively grows inside your blood and your lymph nodes, causing black lesions on the body. And then pneumonic plague has to do with bacteria within the lungs. That's where it will divide. So um, the way that we now know how to keep plague um, at arm's length, essentially, is because we do have sanitation um, protocols in place. Whereas back then, they did not know that it was actually the fleas that were making them sick. Okay, so that was the plague. Let's talk about Lyme disease. So Lyme disease is caused by B. burgdorferi. Sorry, guys, totally butchered that. But it's caused by um, that bacteria. The reservoir is in animals, so such as like deer, squirrel, um, sometimes even mice. And then the vector is a tick. So the hallmark of Lyme disease is that bullseye rash. So what will happen is that if this tick does have this bacteria on him, then it can cause that bullseye rash. So where the tick will bite, you'll have that center of the bullseye followed by a ring around that bite. And that is the hallmark of Lyme disease, is that bullseye rash. But Lyme disease does have 3 stages. So you have the first one, which is where the bacteria will disseminate. It'll cause that rash, so that bullseye one. And then you'll have fever. You'll feel slightly arthritic. And then you may even have a headache on top of that. And then followed by that, the organism will eventually spread to your blood and other organs. So this normally takes weeks to months after the initial infection. And this is where you will feel very lethargic. You'll feel arthritic, and then sometimes neurological or cardiovascular may be involved. So you might have some like severe migraines. You may even start be slightly forgetful, but not dementia. So not that severe. More or less just kind of out of it, essentially. So not really dementia or Alzheimer's. So not that severe. And then stage 3, this is after months to years after being infected. And then this is where you do feel severely arthritic. You're very, your joints are in severe pain. And then some neurological, and then skin. So your skin may start looking kind of dry on the more flaky side. So that's Lyme disease. What else? There's typhoid, malaria, Chagas. Oh, so pretty much we can just go in order, guys. Okay, so let's talk about typhoid. So typhoid, not too big on him because I don't know a lot about typhoid. But with typhoid, it is caused by Salmonella typhi. So that is also a gram-negative bacteria. And the way typhoid will survive is by living inside the macrophages, inside the intestinal tract. And then from there, it can be transported into circulation, so into the blood. With typhoid, you'll get severe fever, you'll get some confusion, you'll have an extended abdomen, so you'll be bloated in your belly, and then also you'll get these maculopapular rashes, which are like these red dots. So they're very small. Also, if the infection does continue to spread, so if it starts like spreading to your gallbladder, causing issues there, A lot of times, at that point, you are called a typhoid Mary. I don't know the history behind that, but I don't know why they call it typhoid Mary. But in order to treat this, you do treat it with antibiotics, and then for the most part, you're okay. Okay, so Rocky Mountain spotted fever. So Rocky Mountain is caused by R. rickettsii. So this is also transmitted through tick bites or lice, so kind of like Lyme disease. But the difference is their rashes. So their rashes will present differently. So with Lyme disease, you get that bullseye, whereas with R. rickettsii, you get these um, pretty much like red dots around your wrists, ankles, and then it can spread to the center of your body, so to your torso. So that's the main difference between Rocky Mountain fever and Lyme disease is their rash presentation. Okie dokie. So I think I also have malaria on there. Yep, so malaria. So malaria, I don't like malaria at all. But it is a parasite. So with malaria, it's not so much stateside, it's more in developing countries, as you can see on the map. So it's more around the South America, Africa, and South Asia region. So um, malaria is transmitted through mosquito bites. And then what will happen is that if you do become infected with malaria, your brain will start inflaming. You'll have difficulty breathing, you'll have anemia, and then you can die from malaria if it does continue. Um, but actually, I think I was reading an article. I believe it was actually no, it was Ebola. Just kidding. Ebola actually just got approved to have a vaccine, guys. Oh, so I'll send that article out to y'all if y'all want it. But anyway, that was with Ebola. With malaria, though, what happens essentially is that a mosquito becomes infected. A mosquito will bite a host, and then what will happen is that 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 parasite, the sporozoites, what they'll do is that they'll travel to the liver cells. They'll reproduce into the liver cells to form miro mirozats or something. I don't even know how to say half these guys. Sorry guys. Will after they reproduce inside the liver cell, what will happen is that those liver cells will burst, and then the parasite will enter the bloodstream, and then from the bloodstream it will continue reproducing, and then at that point a mosquito can bite an infected person and then uptake that, and then the cycle can start all over again with the mosquito. But if it doesn't, what will happen is that it will just continue infecting the person. Okay, so that's the big picture of malaria. And then we have Chagas and Toxoplasmodia. So Chagas disease is caused by also by a parasite, by T. cruzi. So reservoir is rodents, opossums, armadillos. The vector is a kissing bug, which is this guy. So what happens is that he'll bite around the lips and defecate into the wound. So that is how we actually get the parasite, is through his feces in our wound. And then what will happen is that you'll have a fever, swollen glands for a few weeks. Sometimes it can develop into chronic damage of your systems, where there is a lot of damage to your organs, and then with a lot of damage to your organs, including your heart, that can lead to death. That's pretty much all I know about Chagas disease. Now, Toxoplasmodia. So Toxoplasmodia is caused by T. gaudii. So this is the transmission of undercooked meat, so contaminated meat, or through cat feces if your cat does have this parasite. So with Toxoplasmodia, if somebody is pregnant and they own a cat or they're around cats or whatever it may be, they're not allowed to scoop litter. And the reason is because whenever like you're sifting the litter, you can actually be inhaling the parasitic particles from cat feces. And then if a woman is pregnant and she does inhale that, the baby can be affected, and that can cause a stillbirth or neurological damage such as encephalitis, as we can see in this figure right here. So it can be very detrimental to the fetus. So here's the picture of it, but there's also a video that you can watch. It's like 4 minutes. It's super cool. The guy's really cool that did this video. So definitely look at that if you want. I think it might help you study to also get some fun facts so you can help you in differentiating all these diseases and infections. Okay, and then we have lymphatic and elephantitis. Okay, then we have this guy. So this is the last one that we're going to be discussing. So this is caused by a nematode or a worm. Lymphatic fibrillarius, I believe that's how you say it, is found primarily in Africa, Asia, Pacific Islands, and then Indonesia area. So this is transmitted through mosquitoes or flies. What will happen is that you'll get infected with this parasite. This parasite will eventually it'll produce a lot of itself, and then it may even cause a blockage. So depending on where, if a blockage occurs, a blockage may not occur, but generally it will. Depending on where a blockage will occur is how you will classify this infection. So if elephantitis occurs, then that is where you get limb swelling, and that's of the leg. And then if you have hydrocele, that's of your scrotum. So that's in males. So females do not have scrotums. So it will occur in males most likely. So that's that swelling of the penile area. Okie dokie. So that is the big picture for our exam 4. Like I said, guys, I'm going to mainly be asking questions about, like, if I, so let me, for example, so let's see, so right here, so a GON complex shown in the figure. So I would show you a figure similar to, I believe it was this one. Nope, it wasn't this one, just kidding. So, like, I would show you an image something like this. So I would say a GON complex shown in the figure indicates an infection caused by, and then in that case you would answer M. tuberculosis. So that's how a good chunk of the questions are going to be. So I'm going to be putting in those hallmark features, and then from there, based on the hallmark features that I give you in the question, you will identify most likely the causative agent or the disease that is associated with, depending on, I might flip between them. And then I'm going to have some matching on there, and then I pointed out the figure that I wanted you to know, as well as the graph. Like I told you, I was going to have a graph on the test in terms of HPV. So definitely know HPV, and then how to read a graph. Also, guys, I told you to look up those supplemental case study questions. That will definitely help you on the test. If you have any questions, definitely ask me. If not, I will see you all in class.